Hello. Thank you for the opportunity to tell you a little bit about the research I've been doing for the past several years. My area of focus is developing, testing, and implementing exercise programs to improve mobility and promote independence in community-dwelling older adults. First, a little bit of a background on walking difficulty. Walking difficulty is a common and costly problem for older adults. Walking limitations affect up to 76% of older Americans and account for approximately $42 billion annually in healthcare costs. The good news is exercise can improve walking. However, many of the group exercise programs out there focus on fitness, such as improving cardiovascular health and strength, and not really focusing on the quality of walking. To fill that need, we created the On the Move program, which is a timing and coordination group exercise program, which focuses on improving the quality of walking in older adults. We developed this program over the past 20 years, and we're happy to say that a few years ago, it was designated as an evidence-based program by the Administration for Community Living. This means that community-based organizations can use their Title III-D funds from the Older Americans Act to financially support the program. Though this is not a ton of money from the Older Americans Act, it does help these centers implement the program and helps to sustain the program over time. So PCORI encourages engagement of key stakeholders throughout the research process. And here I'm showing the PCORI engagement rubric. It's important to include engagement in all stages, planning research, conducting research, and also at the end when it comes to disseminate the findings. Who should be involved in the engagement? Well, we like to call the people who are involved in engagement stakeholders. And what is a stakeholder? A stakeholder is an individual or group who is responsible for or affected by health and healthcare related decisions that can be informed by the evidence. The 7Ps framework, which was developed through use of a deductive-inductive method, suggests that stakeholders may be organized into 7 types: patients in the public, providers, purchasers, payers, policymakers, product makers, and principal investigators. When you are planning, conducting, and disseminating your work, it is important to identify which of these stakeholders should be involved. In a study by Concannon et al. In 2014, they investigated who were the most frequently engaged stakeholders, and they found that the most commonly engaged stakeholders were patients, followed by clinicians or providers. The other stakeholders, purchasers, payers, policymakers, and product makers, were infrequently engaged in research. Therefore, I would encourage you to think beyond the patients and the providers, and I would challenge you to include as many different stakeholders as appropriate in your research. So when I say it takes a village to plan, conduct, and disseminate research, the various stakeholders are the village. Traditionally, we think of researchers producing the research on their own without much input from others. And then the hope is that the stakeholder or the consumer will use the research in the findings. We know that this hasn't worked, so we need to do things differently. The goal is to work together to be co-producers of the research. Engaging stakeholders early and often throughout the process will improve the quality and impact of the research, as it will likely be more relevant to the consumers. There are many ways to engage stakeholders, including diverse forms of engagement offers the potential to better align the priorities of relevant partners. Some examples of ways to engage stakeholders include community discussions or focus groups, networking or individual meetings, and advisory panel or advisory boards. When engaging stakeholders, it is critical to remember that the relationship should be bi-directional. Do not just focus on what your needs are, but try to identify what the stakeholder can get out of the relationship as well. Basically, what is in it for them? What are some of the benefits of stakeholder engagement? Well, stakeholder engagement helps to realign healthcare research with the needs of clinicians, patients, policymakers, and payers. And this will hopefully improve the relevance of the research questions. If we are involving these stakeholders in the creation of the research questions, like questions that they're interested in. By including stakeholders in the process, we also increase the transparency of the research activities. They know what we're doing and they know what's going on when we conduct the research. And then hopefully it will also accelerate the adoption of evidence into practice. If we're asking questions that are most important to these stakeholders, then they're more likely to use the results once we get them. Stakeholder engagement also comes with challenges. Probably the most eye-opening thing for me was the amount of time it took to cultivate and develop meaningful relationships with stakeholders. This cannot be rushed and often needs to be done in person. A good example is I would travel to senior centers throughout the center to get them involved in my research. After our meetings, they often would invite me to stay and have lunch with their members. And, this was always a struggle for me. Should I hurry up and rush and get back to the center or get back to my office and do research? Or should I take that extra time and sit and have lunch with the individuals at the community center? By taking that time to sit and have lunch, it meant a lot to the staff and members. It showed that I was interested and wanted to be a part of their center, and this often strengthened our relationship. Other challenges include the cost or resources needed to engage stakeholders. This does take some funding, and I encourage you to be creative in trying to find pilot funds to help support stakeholder engagement. It also involves researcher flexibility. You're not just dealing with yourself. You need to work around other people's schedules and wants and needs. It takes time to build trust among researchers and stakeholders. There's this commitment to maintain contact and participation. So not just contacting them once, but keeping them involved throughout the process. There's difficulty establishing stakeholder representativeness throughout the course of the research. So once again, trying to involve a diverse group of individuals. And then we also have to think about if we're including patients and family members as stakeholders, they may be dealing with different medical conditions or troubling conditions, and adding this additional responsibility of being a stakeholder or participating in research might add more distress. So just trying to think about that and be respectful of their time and their condition. Now I'm going to transition to telling you a little bit about my research and the engagement of stakeholders throughout the process. We use the NIH stage model of intervention development for our research surrounding the On the Move program. This model starts at basic research and intervention generation and refinement at stages 0 and 1, and includes efficacy, effectiveness, and D&I studies, moving through stages 2, 3, 4, and 5. You can follow the outer circle and progress through the stages in order, or as the arrows in the center represent, you may skip some stages or actually move backward stages as needed if you need to refine the intervention or move back to an earlier stage in the research process. So for stage 1, intervention, generation, and refinement, we involved providers and participants as our stakeholders. So the first thing we did is we met with providers, and the provider was the University of Pittsburgh Medical Center, or UPMC, senior communities. We met with these individuals or leadership of the senior communities because they had learned about our research that we were doing, studying a physical therapy intervention that was delivered one-on-one from a physical therapist to a patient. And they saw the results and said, wow, this is really great. But is there a way that you could take those exercises and develop them into a group program but we can then, have a group class at our facilities. So that was the challenge. I accepted the challenge and I got together with other physical therapists and fitness instructors. We sat around a table in a conference room and we initially developed the program that we thought was ideal. Because once again, we were the experts. We decided what exercises should be done, the order of the exercises, the length of the program, whether it should have music. Once we had a class that we thought was pretty good, we assembled a group of older adults and we had them do a sample class. After they participated in a sample on the move class, we held a focus group with them to get their input on the program, what they liked, what they didn't like, and what they would change. Not surprisingly, they provided lots of feedback on the program. So when we initially created the program, we designed it to be a 30-minute exercise class. The older adults said to us they wanted a longer class. They said, if I'm going to come out and exercise, I want to be there for more than 30 minutes. But they said, I may not be able to exercise for a full hour. So let's create a class that's about an hour long that takes a short break in the middle so that we could get a drink of water or rest for a little bit. We also originally had selected a wide variety of music to go with the exercises. And most of the older adults really said that they liked music from their generation. And so now what we do is we encourage our instructors to really talk to their participants to figure out which music they would prefer when creating their playlist. Also, the older adults said that they wanted a lot more information or education about the exercises. They just didn't want us to show them the exercises. They wanted to understand the rationale behind the exercise. They said by understanding the rationale, they would be more likely to want to stick with it and continue doing the exercises because they would understand the why of the program. You can see in the picture on the left where the older adults are standing next to chairs. They're doing stepping exercises individually, and this is part of the program. What they told us was, yes, we like these individual exercises, but what we really like is the class setting. And is there a way that we could do exercises where we interact with others in the class? And so you can see the picture in the bottom right, which shows the older adults doing a step and passing the ball to a partner across from them. This is facilitating the exact same movement, a step across, but now they're interacting with a partner, which helps with socialization. So based on the feedback from the older adults, we added more of these partner exercises or group exercises to the exercise class. So after the program was developed, we ended up conducting a stage 3 efficacy trial in the community, which was funded by PCORI. And the first thing we did is we got some provider input. And once again, the provider was UPMC Senior Communities. And they helped us in 2 main ways. The first is we wanted to compare this new program, the On the Move group exercise program, to what was standard or usual care. We needed their help in defining what usual or standard care was in their facilities. So we met with them and their fitness instructors and defined and operationally defined what the standard of care was that we would use as our comparison group. And then secondly, and probably most importantly, they provided input into the aims. And let me I'm going to go to the next slide to show you. So originally we had a very simple research design. It was going to be a cluster randomized trial where we had 28 facilities. Half of the facilities, or 14, would be randomized to receive the On the Move program, and half of the facilities would be randomized to the comparison group or the standard of care program. Both programs would be delivered by my research staff. We would baseline test our subjects. They would do 12 weeks of exercise, and then we would do post-testing. And the goal was to enroll 140 participants into each arm of the study for a total of 280 participants. Very simple design, very doable. We showed this to our providers and they said, yeah, this is great. But what we're really interested in is, people come to our centers and they want to do research. And when the research is over, they leave and there's nothing left behind. They were very interested in if we could train their staff to deliver the program and if their staff would get the same outcomes as our research team. So we ended up modifying our research design and adding a second aim. So in addition to, we would randomize 14 facilities to on the move and 14 facilities to the standard of care program. But within each of these arms, we would randomize people to either receive on the move from my research staff or to a delayed group who would receive on the move taught by someone trained at the facility to deliver the program. This would allow us to answer three big questions. One is, when taught by my research staff, is on the move superior to the standard of care, which was aim one. The second question we could answer is, when delivered by someone at the facility, is on the move superior to the standard program? And then we could also compare on the move delivered by my research staff to on the move delivered by someone at the research or someone at the facility. This was, a great change to the study. It increased the sample size dramatically. I mean, it doubled it. It went from 280 participants up to 560. And it was a big change to the research design. I made the mistake of waiting to share the original research design with the stakeholders. Then it was a mad rush to redesign the study prior to submission. I think 10 days before the grant was due was when I met with the provider and ended up changing this aim. We did manage to change the protocol and get the grant submitted, and luckily it worked. And the reviewers commented on the importance of this new aim, the sustainability component, about being able to have the facility staff do it. So by listening to the input from the provider made a big difference and is likely one of the main reasons we were funded. Also, in the stage 3 efficacy in the community, we created 2 community advisory boards, which was made up primarily of patients and providers. And these community advisory boards provided a lot of input. We would meet 2 to 3 times a year, usually during lunch. And, we would get their input on things like the various study materials. They helped us pick our study logo. They helped design the recruitment flyer, giving us input on the wording, what made most sense. They helped identify recruitment and retention strategies. They served as project ambassadors. Many of them would go with us to the different sites to help us recruit, and they would provide testimonials about the program. Part of this trial, we had a qualitative aim where we did focus groups and interviews, and we used the community advisory board as a way to pilot test these questionnaires and interview guides. And they provided input once again into the language and the wording. And then lastly, and probably most importantly, they advocated for a study change to the funders. Partway through the study, we realized we were having difficulty identifying people at the facility to train. We were having a hard time meeting our quota as far as recruitment. And our advisory board kind of went to bat for us. They said it's not that we were failing, but we were actually answering the question by saying it's very difficult to identify and train people at the facility to run the program. And not that that was a failure, but that was actually an answer to our question. They wrote a beautiful letter that we ended up including in our progress report to PCORI, who then allowed us to modify our aim and our sample size. And then lastly, we involved stakeholders in stage 5, or dissemination. We were lucky enough to receive a Eugene Washington Dissemination Award from PCORI to help to disseminate the On the Move program. In this Eugene Washington Dissemination Award, we identified key users or stakeholders, and these were community organizations, group fitness instructors, and older adult participants. We engaged the key stakeholders or key users through audience research, focus groups, in-depth interviews, and surveys. And we basically took a marketing or a business approach to dissemination. And we partnered with our colleagues in the business school at the University of Pittsburgh. And they helped us do this part of the project by conducting the audience research, the focus groups, and the interviews. We did those things in order to understand the needs of the stakeholders or the key end users, and then they helped us define targeted promotional activities that we were to complete. Some of the things that we learned through this process were, the first is we really needed to focus our efforts on the community-based organizations. Prior to this, we were spending most of our time targeting our dissemination efforts to the on-the-move instructors, which was great. We got a lot of instructors trained and on the move, but then they had no place to hold the classes. So, with input from our key end users, they said, first, you really need to get the organizations on board. Make sure you have a place to offer the class. Once you have a place to offer the class, you get the instructor, and then you notify the participants. And so we were kind of doing things out of order. Then the other thing that they identified is that we really needed to create some new materials, which was a social media presence and an informational video. And they also wanted us to update some of our resources, such as our print flyers and our website. The input that they gave us on creating and updating these materials were critical. Some of the things that they really wanted us to focus on. They wanted us to have a very clear call to action. So depending on who the material was for, if it was for the organization, the call to action was, we want you to host the On the Move program, or become a trained instructor for the instructors, or participate in On the Move for the participants. So the call to action was different depending on who the end user was. They thought it was very important that we highlight this, that we were an evidence-based program in this designation. They said, that's something we should be proud of, and it should be prominently displayed on all of our materials. They also said it was important for us to promote the message of remaining independent, the socialization aspect of the program, and that the program was fun. Many of our users said the reason people pick programs to participate in that they feel are fun and enjoyable. And so we really needed to convey that message. They wanted our materials to represent a racially and ability level diverse group of individuals. So not just all individuals that look the same, that are highly fit, but they wanted us to identify people who would be the perfect candidate for the program and use those types of individuals in our materials. They wanted us to prioritize real program photos over stock photos. And any of you who've worked in the aging field, you know that there is this group of stock photos that you see everywhere. It's usually very fit seniors with smiles on their faces that kind of look quite generic. He said, stay away from those and get your own pictures so that it really represents the On the Move program. And then lastly, they said it was really important to maintain the University of Pittsburgh branding. Especially in our region, Pitt is well respected. And because this program came out of the University of Pittsburgh, they thought it was important to use that, to make that front and clear on all of our materials. So here's just some examples. So on the left here is the original website. It's mostly in gray and red. You see some yellow. You see a stock photo of two people walking outdoors. Has nothing to do with the On the Move program. We modified our website using Pitt colors, University of Pittsburgh colors. We have the logo here. Just so happens one of the gentlemen in one of our classes had a Pitt t-shirt on, all the better. This is an actual class. You could see the people smiling, laughing, interacting, the socialization. So once again, trying to hit a lot of the things that our end users mentioned on us to do when we update our materials. And then here, this is one of the brochures. It's a trifold brochure that we give to centers that they can use to market the program. On the left here, you see the brochure was black and white, stock photos of feet. Not very exciting. Our updated brochure is done in color. Once again, it matches the colors of the website and also the University of Pittsburgh. We highlight here that it is an evidence-based program. It's front and center on the front of the brochure. You see a group of diverse individuals with different body types, different races, and different genders. And these are real people and real instructors doing the On the Move program. There's a clear call to action about what do I need to do to offer the program? And this is really geared towards the sites. And we highlight the independence, fun, and socialization. Once again, I think this picture in the upper right-hand corner shows the two ladies joking around and having fun, which once again is something that we want to support with our program or try to highlight. So this is just another example on how we incorporated some of our key end user stakeholder input into the dissemination of our program. So I just want to close with a few of the lessons I've learned about stakeholder engagement over the past several years. First, it's not always easy, but it's worth the effort. It does take time and energy, but in the end, your work will be so much better for it. Before I go on, I just want to say that the picture here is one of our community advisory boards after one of our meetings. So you can see it is a very diverse group representing of different ages, and we have social workers, we have a nurse, we have older adult participants, and we have fitness instructors. So a wide group of people participating in our advisory board. You also want to demonstrate through your words and actions that you value them. One of the big things that we did with our community advisory board is that we would, whatever we were working on at one meeting, and they provided us feedback. At the following meeting, we would show them how we use their feedback and how we incorporate it into the materials. So an example is if they suggested that we make changes to our flyer, we would change the flyer and bring it back to them at the next meeting so that they could see that we incorporated their changes. Also, I think it's very important to involve them early and often. Learn from my mistake, especially when I was talking about the provider. You do not want to revise your grant application 1 week before it's due. The earlier you can get them involved, the better. And also keep them involved throughout the process. I think it's important to involve a variety of stakeholders, not just different types representing the 7 Ps, but also a diverse group of individuals. By adding diversity, you just get more valuable input. And then lastly, it does take time, energy, and money to involve stakeholders. And I would encourage you or challenge you to look for different opportunities to fund these activities. I was able to obtain pilot funds from our Clinical Translation Science Institute, or our CTSI, also from our Pittsburgh Pepper Center, to do some stakeholder engagement. And then also I was able to get money from PCORI through their Eugene, Washington initiative. So there are opportunities out there. You just need to look for them. And I think that is all. And I thank you for your time.